Okay, it's 2 past the hour. So thank you all for being here. We're very excited to have a stellar panel that has come together to talk about this very important topic of workers at the forefront of healthcare, health system resilience, of global health security, and responding to the needs of people when they need care the most. So I will not go on anymore, and I will introduce the agenda and our first speaker. We will have opening remarks from the president of the Consortium of University of Global Health Board. And then we will have our first panel on the reality on the ground, considering the massive changes that we have all seen in global health funding. We will move to a second panel that discusses policies and perspectives around the massive funding changes that we are seeing. We will have a breakout session where all of you will be able to contribute and discuss positive, proactive things that we can do individually and collectively, whether it's at the national level or at the most grassroots community level, to respond and to build resilience through this very, very difficult time. And then lastly, we will bring those back. We would like people to bring back their ideas from the breakout rooms to identify a pathway forward and really a call to action. And we invite you all to join us at the CUGH conference in April in Washington, D.C., a very strategic location for the 2026 conference. And we will continue this discussion and this call to action at a panel which has been accepted, thankfully, to the conference. So I will hand over to Professor Nancy Reynolds. Nancy Reynolds is a professor and associate dean of global affairs at Johns Hopkins University School of Nursing. And as I said, she is the president of the board of the Consortium of Universities of Global Health. Over to you, Nancy.
Thanks so much. And good evening, good afternoon, everyone. It's such a pleasure to be with you today and to join in this important discussion on workers at the forefront, protecting global health workforce in an era of financial contraction. Thank you for joining us for what I believe is one of the most critical conversations in global health right now, because at the center of every health system and behind every health gain we celebrate stands the global health workforce. And today we meet at a time of deep contradiction. On one hand, the world continues to ask more of health workers than ever before. But on the other hand, the financial foundation underneath this workforce is becoming increasingly unstable. Shrinking donor budgets, political uncertainty, and growing national fiscal pressures are reshaping what is possible for providers at the front line, for educators and training institutions, and for health systems that depend on them. Across the globe, we are witnessing substantial funding contractions, whether through reductions to PEPFAR country budgets, delayed or diminished multilateral support, constraints of new geopolitically driven regulations that restrict collaborations and NIH subcontracts. These trends are not abstract. They reverberate directly into the daily lives of nurses, community health workers, midwives, public health officers, and the teams that support them. And we know this story because we have lived it before. When funding pulls back suddenly, the consequences are immediate. Vacant positions go unfilled, training programs stall, retention declines, as work intensifies and salaries stagnate. Migration accelerates, especially among nurses, further hollowing out systems and communities who may lose trust in services as they become inconsistent or unavailable. And these are not simply human resource problems. They are problems of health security and health equity. We cannot protect populations from pandemics, avert maternal deaths, or manage HIV and TB without a stable, skilled, and supported workforce. And we certainly cannot do it if the workforce is operating under policies that reward short-term cost savings at the expense of sustained capacity. This year alone, WHO estimates a global shortage of 10 million health workers, disproportionately affecting low and middle income countries. Nurses, who make up nearly 60% of the global health workforce, carry much of this burden. They are frequently the first to feel the pressure and the last to receive the resources needed to adapt, reskill, or lead new models of care. Yet they are the ones who hold health systems together in crisis and who enable long-term continuity of care. As funding tightens, the risk is that the nursing workforce becomes the cushion that absorbs shock rather than the catalyst for resilience. And let us be clear, financial contraction is rarely neutral. It hits hardest in settings where health systems are already stretched, where workforce density is low, where training pipelines are fragile, where health workers are expected to do more with less. In these places, even small reductions in donor contributions can lead to deep and lasting disruptions. But this panel is not only about identifying the problem, it's also about widening the lens. Because what we are experiencing today is part of a broader shift in the global health landscape, one marked by geopolitical fragmentation, evolving donor priorities, and a move toward domestic financing that, while necessary, is uneven and unpredictable. Many governments want to invest more in their health workforce, but they are navigating constrained budgets, inflationary pressures, and competing national priorities. Within universities and research institutions, we are seeing the ripple effects of reduced global health funding as well, through hiring freezes, limited trainee support, shrinking opportunities for global exchange, and reduced resources for international partnerships. These dynamics not only weaken the research enterprise, but also the training and leadership pipelines that prepare the next generation of global health scholars and practitioners. And this is precisely why today's conversation is so important. We need to illuminate the real-world consequences of these trends, not only through data, but through the lived experiences of those at the forefront. We need to understand what happens inside hospitals, clinics, community organizations, and academic institutions when funding contracts. And we need to hear directly from providers, educators, policymakers, and donors about what solutions are possible even when resources are tight. Because the reality is this, even in times of financial contraction, there are strategies that work. There are policy levers, workforce innovations, and financing approaches that help sustain capacity, protect training pipelines, and support the emotional and professional well-being of health workers. There are ways to safeguard progress without compromising equity or quality. But these solutions require intentionality, they require political will, they require centering the voices of the workforce, not as an afterthought, but as the foundation for decision making. So we have brought together the panel for precisely that reason. Over the next 2 hours, you will hear multiple perspectives from frontline providers delivering care under resource constraints, from academic leaders who are innovating within educational and resource systems, from global agencies navigating shifting donor landscapes, and from policy advocates who remind us what is at stake for the health equity and global health security. And our objectives are fourfold. To illuminate the problem, to understand how global funding shifts are affected how they affect health workforce stability and training pipelines around the world, to bring forward diverse perspectives, to hear the realities and priorities of those closest to the work, to identify innovative strategies, approaches that can sustain, strengthen, and protect the workforce, even in financially constrained environments, and to issue a call to action to articulate what governments, donors, institutions, and global health leaders must do now to support the people who support the world's health. So, as we begin, I invite us to hold this one guiding question in mind. What does it take not only to train a resilient workforce, but to sustain one in a moment of change and uncertainty? And with that, it is now my pleasure to introduce our first speaker, Dr. Juana Paola Bustamante Izquierdo, who is a labor economist with WHO. So thank you very much.
Thank you, Nancy. Thank you for this. So I'm going to share my screen. Let me know if everything is going fine here. Yes, are you seeing the first slide? I hope you are.
Yes, looks great.
Okay, that's very good. Just let me go back to this, to see you. Okay, now I'm seeing you. Okay, this is fantastic. So, great. Thank you so much for having me here today. So today I'm going to present you some general key facts to sparkle a little bit the conversation. And we're going to talk about investing in the health and care workforce in the context of challenging macro fiscal environments. Always thinking about this question that we just heard. So we're going to look a little bit on the contemporary demands on the health systems and health workforce, and what are the health workforce challenges right now at the moment. So we have here the contemporary demands of the health workforce. So it's not just about the SDG, the health systems must align health services and workforce development to the sustainable development goals, but it's not only about that, it's also globalization. We're talking about global interconnected of demands. We're talking also about the conflict and war and how ongoing conflicts require resilient health systems and adaptable workers to deliver health. We're talking about climate change and how we must be prepared to that, and health workforce, what is needed, what is required to actually be prepared to that. The infectious disease outbreaks, innovation, being capable of adopting new technologies, ethically applied technologies, urbanization, refugees, antimicrobial. We have all these kind of things. So it's not just about thinking something specific on the primary healthcare, but also responding to all of these. And we need health workforce to do that. So the cuts and reductions in ODA, or official development assistance for health, are going to affect this already. And they are going to affect already when health workforce, we all know, is a critical element for health service delivery, but it already faces many, many challenges. Let's remind us some kind of the challenges that we have. We have countries that, although they have huge shortages, they have unemployment or underemployment. Why is that? We already know something: working conditions, salaries, remuneration. We have shortages and surpluses inside the country. We have wages and working conditions issues. We have a misalignment between education and capacities and employment. Migration, a huge, huge issue, and quality and performance of care. So we have already we're facing these challenges in the health workforce. Have we advanced in any of these challenges? Yes, we have. So global shortage of health workforce has been declining. Here you have 2013. In 2013, we had a global health workforce shortage from 18 million. And in 2023, we were already in 14.7 million, and WHO is projecting a global shortage of 11 million by 2030. However, there is inequity across regions, and you can see here already in 2030 that around 70% of this shortage will be concentrated in two regions, the African region and the Eastern Mediterranean region. So yes, we have an advance on shortage declining. We still have lots of things to do, and we have a lot of inequities. What else can we see? We are having, in part of these inequities, in these shortages, a huge percentage, as well, 20% is medical doctors. But what's going on? We're seeing that around 46% of the countries are actually having medical doctors that are over 55. In nursing, we have 13% of countries, and in midwifery, 23% of countries, almost 24% of countries. So this is another challenge that is coming, and is coming along with the shortages and the funding of health workforce. We were seeing also a topic in terms of migration. So in terms of migration, we can see that the share of migrant health workers, both foreign-born and trained, have been increasing in OECD countries. So you can see here in the blue line, that you have the foreign-born doctors and the foreign-born nurses. So you have the foreign-born nurses in 2000, that it has increased from 11 to 17. So it's a continuous increase, and then you see the foreign trained doctors and the foreign trained nurses. So we haven't been able to stop that, to address that, and this is a huge issue. It's like a way of subsidizing low and middle income countries, subsidizing high income countries. That's how we see it. So how can we make a change on this? We have all these issues. We have progress on closing the workforce gaps, but we need more investment. In this environment of macroeconomic issues, we have a huge financial gap for achieving SDG 3. And this gap is concentrated on health workforce. So you see here on the left-hand side, the first graph that I show you on the shortages. We have advanced in this. We have huge inequities, and we're still facing issues and challenges in terms of remuneration, working conditions, migration, and aging of the health workforce. But on top of that, we have estimates here on the right-hand side on what is needed in terms of investment to achieve SDG 3. And the huge one, this orange plot that you see here, is about health workforce. On top of this, we have also the fiscal constraints. So you can see here that although we have that the health workforce is one of the top priorities and funding needs, there's low health budget prioritization in low and middle income countries. How do we see that? How do we see the budget prioritization? So you see here the domestic public spending on health, and it is decreasing. This blue line is decreasing. It's not increasing. That's a prioritization among the total budget of a country. So we can see this. We can see also the rising of debt, service cost, and now on top of this, we're having the decline of aid. And when we think about this, we said, okay, what are the sources of financing? What can we do, right? Where is the health investment, and where can we invest and bring money to invest in health workforce? So we have this, and we have again this external aid that you see here on the third point, that we published a short blog at the beginning of the year on the estimates given the OECD countries that were reducing their investments on health, on the estimates on how much the external aid will decrease. And we estimated a 40% decrease for 2025. So if you see that these are the investments, the sources for investment on health workers and on health, and these decrease, then it actually affects quite a lot. What can we do? right? We have all of these. We have on the World Health Assembly the resolution that has been approved in EB 156 on accelerating action on the global health and care workforce. We have the different areas of actions for member states. We have accelerating implementation, international cooperation and investment, addressing these shortages in education and employment capacity, promoting decent work for better remuneration, better working conditions, prioritizing the safe and protection. But on top of this, and in this environment of macro and fiscal constraints, how are we going to do it? So we have to have these actions in mind. Keep working on this, but then the idea of today is also brainstorm on new ways or channels or path to go through. One of these, and I will close with this, is to have also a shared understanding of the key drivers of health workforce expansion. And this is important in an area of cut in the international aid, but also this is linked with the constraints and fiscal constraints of the countries and the prioritization, because we keep saying is health needs to prioritize, and in the budget of health we need to also understand how to prioritize the health workforce, and we need to address this dialogue in a different way with issues that can connect different ministries and different stakeholders to actually have a sustainable and sustain the transition on the budget towards health workforce. Thank you very much.
Excellent, and thank you to both our first two speakers, Dr. Nancy and Dr. Joanna, for your framing remarks. It really provides an excellent context on which to move into the next session. Ian, I'll go ahead and share my screen if that is okay. One moment. We'll bring up our panel. And I will start the panel with a few framing remarks, and then we will introduce each of the panelists. And I have given them some guiding questions to speak about. And we have a very rich panel here to further unpack the challenges that we face. So the WHO released a report on November 3rd. Let me just turn on my video. Moment. Apologies. Released a report on November 3rd that projected a drop of 30 to 40% of external funding for health compared to 2023. This reduction has already caused immediate and severe disruption in low and middle income countries, and you will hear some real examples for people living through these panels. And countries must rapidly respond in many respects and make difficult choices, including what complement of healthcare workers they can afford to sustain when all aspects of the health system are being affected. ICAP leads a Sequin network on quality and impact of HIV services, and they currently are working with countries to develop minimum packages of care in line with the current financial changes. We know that layoffs and job losses are very real, from the loss of NGO funding to CBO funding and diminished national MOH budgets. Training and capacity building, as you have already learned, have been disrupted during this period of bridge funding as new priorities are planned through the U.S. Global Health Security Strategy. Both the quantity and quality of health workers will suffer, but it is not only trainings, mentorships, and supportive supervision which we know drive and sustain quality improvement. The mental health of health workers will be challenged as they are expected to do more with less. Dr. Tedros, the Director General of WHO, notes, sudden and unplanned cuts to aid have hit many countries, costing lives and jeopardizing hard-won health gains. The loss of support for the health workforce who are at the forefront of care, the community health workers, nurses, primary care doctors, and other providers who keep people healthy and keep people from having to be referred to higher levels of more expensive care is particularly worrisome. The impacts on HIV services, which I primarily focus on, are being documented, but we must also think about how many people with other chronic conditions like diabetes and hypertension will go without medications and suffer complications like worsening heart disease and stroke. These consequences are harder and more costly to treat. They remove people from the workforce and affect economies and can push families into poverty. A vicious cycle of ill health and economic fragility will ensue. Not surprisingly, community-based workers and community health workers, community and midwives are particularly impacted. The Partnership for Maternal, Newborn, and Child Health recently completed a rapid survey which showed that amongst maternal, newborn, and child health partners, 89% of partners faced reduced or uncertain funding. I'll say that again. Those that are focused on maternal, newborn, and child health, nearly 90% of them faced reduced or uncertain funding. 81% reported moderate to severe impacts on advancing women and children's health goals, and 62% had to downsize their programs. 37% temporarily suspended activities, and nearly 20% closed completely. 79% cite flexible core funding as the top need to navigate global uncertainty. We are clearly in a new phase of health and health development, and we need to address this with action and with passion. As part of CUGH, as a small working group, we completed a rapid survey which showed that amongst people engaged in public health with participation from all regions of the world, that which was identified as one of the biggest and most profound outcomes was a loss of trust in the United States as a global partner in health and development, and what it will take to rebuild that trust, let alone rebuilding the services that have been impacted, are yet to be determined. And that is what we want to discuss today through the development of a call to action. Now I would like to introduce our panel. If you could just stop your share, Joanna.
Yes, I'm not sharing anymore.
Okay, I'm not sure why it was lost. Okay, there we go. Apologies. What I would like to do now is hand over to our four panelists. I will begin with Rachel Dusum. Rachel is an independent consultant, and she is a passionate advocate for frontline health workers, and she is a steering committee member of the Frontline Health Workers Coalition. I'll hand over to Rachel now for some opening remarks. Thank you, Rachel.
Thanks, Susan, and thanks to Nancy and Dr. Juana Paula for some of these really pivotal remarks to lay the foundation of where we are, if it can be called a foundation. I feel like 2025 has been a bit of a storm in the sea, so finding that solid ground is certainly one that we are all trying to arrive at. I want to start by acknowledging the occupied Piscataway land that I live and work and play and heal on. And as you know, here in the United States, we celebrate the change of the seasons and the Thanksgiving harvest. So I'm just going to reframe and reiterate some of these health labor market realities in terms of pie and the Thanksgiving pie that remains in my refrigerator to be finished. So, like like a tart or a camembert, as we're talking in other contexts. So as Dr. Juana so well stated, the pie for health is simply not big enough. When we look at the lofty goals of the Abuja Declaration for public sector budgets to dedicate a minimum of 15% to health. I believe the latest is that only 2 middle-income countries have achieved that. There is not enough investment in health overall. And when you look at the availability of external financing and the fungibility and flexibility that it may provide for ministries of health to respond to emerging needs or invest in programs, that safety net is not there. And so you do see that jobs are not being created, partly because within that overall pie for health in the public sector, generally, health workforce salaries compose between 50 to 80% of that pie. So not only is the pie smaller and constrained, but those salaries are not generally, and that slice of the pie that is salaries are not quite secure enough. The fair pay is generally insufficient. Across the world in 2025, we've had a lot of conflict, fragility, and instability. I think it was 50 countries that had elections across the world. And inflation is a great challenge, and that you see that overall slice of the pie for salaries is not enough relative to living wage requirements. I was digging into some profiles of countries to look at what the entry-level public sector salary is for doctors and nurses relative to the living wage. And just to give you a taste, in Tanzania, the entry-level public sector doctor's salary is only 3.3 times that of the living wage. For an entry-level public sector nurse in Tanzania, it's 1.9%. So for these jobs that are, ideally for the most upwardly mobile and should be the most competitive, that's not great. It's a lot worse in other settings. In Ethiopia and Nigeria, an entry-level nursing salary is 1/4 of the living wage. So the expectation that doctors and nurses and other health workers should be operating below the living wage in the countries where they work is truly challenging. When you look at the overall slices of the pie, we recognize that health worker remuneration overall is complex. Beyond just those public sector salaries, we see a number of different sorts of stipends, bonuses, top-ups, and other sorts of financial benefits that health workers may have. That tends to be where our external partners are committing. They're committing less and less and have committed historically less to supporting salaries for concerns of sustainability. Footnote PEPFAR, I think we'll talk about that at some point later. But that then shrinks further, and these health workers are further stressed and constrained. Retention mechanisms, those sorts of bonuses are not sustainable. And for volunteers who are dependent on stipends for outreach and so forth, that's just challenging. Further, when we see fiscal constraints, it may delay salaries that are arriving or make them less consistent, particularly for those public sector staff. I think the other thing to recognize is that in decentralized settings, when we're looking at health workforce remuneration and support, that a lot has been falling increasingly and appropriately with their designated authority to local governments. There are a lot of bureaucratic processes and navigating between some of the external financing that tends to land at the central level and identify how and where things can land in the decentralized regions and districts for health workers support is really challenging. I'm then just going to briefly talk about the whole rest of the pie, because I truly believe that any positive investment in the health system is positive and is a win-win for that health worker. It helps in their job satisfaction today to be well equipped, to have adequate infrastructure, electricity, water and sanitation, to facilitate their job and to keep them safe. And we also see a lot of external financing that has been pulled, that has been providing a lot of that key systems level support, whether that's for supervision, the fuel in the tank to get the district managers out and support, whether that's support to the digital information systems that are allowing for timely information to be shared and for resources to get where they're needed most. Whether that's ensuring adequate equipment, supplies, medicines, ensuring continued learning and training. All of those are taking a cut across the board. We can continue to talk, but I think I'll stop there, Susan, and see what else we want to discuss today. Thanks.
Great. Thank you. I'll now hand over to Judy Cagnola. Judy is a nurse and passionate nurse educator. She is also the Vice President of AfriHealth. Over to you, Judy.
Thank you so much. And just because of time, I won't repeat what my esteemed colleagues have said. Thank you, Dr. Juana Paulo, for your reframing and laying the foundation. And also to you, Rachel, as well as you, Nancy, in terms of just looking at the devastation that has happened this year. As we come to the tail end of the year, we kind of see I don't want to repeat the devastation that's been caused by these funding cuts to Africa, and I'll confine myself to what I know, which is my home, Africa. We know there are more birth complications. So often people look at mortality as just death. So we look at the death of a mother who was died giving birth, or the death of the child himself or herself, or both. But over and above that, it's important to remember that complications arise because the labor force at that forefront, as that mother is in labor, is either reduced, I think like Nancy has said, and Dr. Juana and Rachel, all of you are alluding to that, and I won't repeat that, but the lack of a skilled attendant at that particular time results in a complication. So while there may not be any mortality, you end up with a lot of complications, which further strain the health systems. So sometimes it's important to note, and I think the point I want to make here is that the nuances are lost, and we must not lose those nuances. So that's number one. We have a lot more birth complications because either the health worker is not there, because like in Kenya, my own Kenya where I live now, health workers have been increasingly going on strike. Nurses, doctors, the medical lab personnel, clinical officers, pharmacists, all of them have been going on strike. So at a certain point in time, when you go in, that health worker is not there. Then, of course, there are challenges that have come. People have lost their jobs. There are challenges that have come because of the reduced funding. People migrate for greener pastures. So whatever reason may be, that person is not there when you need them to be. We've also reversed a lot of the gains in Africa that we had made. Malaria is one of them that I find very, very sad. Malaria is a disease that really ravages us here in Africa, and we've made tremendous gains through all of this support and funding with our partners, and US being one of the big ones, and that now is not there. So it's very sad that you find that now in Nairobi, I have a friend of mine whose son is admitted with malaria, which is something we had almost forgotten. So that is very important to recall, because then the little shilling which would have now gone to help something else is going to do something that we thought was already done and dusted, and we were sort of saying, oh, we've come out of that crisis, we've jumped the hurdle, we are in a new and better day. Now we are going back to the dark days. There's also been a lot of outbreaks. We have certain outbreaks. I think, Teresa, you're aware of this because Teresa works in that county in Kenya where we have, chikungunya. And chikungunya, some of these forgotten, if I may call them, or less important viruses that have now reared their head. And these outbreaks also as a result of the contraction, the financial contraction as a result of these cuts that then impact the frontline health workforce, most especially nurses. We have general doctors, public health officers, environmental health officers, midwives, critical community health workers, all of that who do a great job there. I mean, we've just celebrated the World AIDS Day a few days ago here in Kenya, and the reports and the studies are saying that now, because of the funding cuts, we have 6 million new HIV infections and 4 million more deaths by 2030, which is just a few, 4 or so short years away. We have an increase in cholera, for example, because one of the things that the US funding did was fund a lot of the WASH programs, water, sanitation, hygiene programs. So now, in places which we knew we no longer thought about cholera, we have an upsurge in cholera. My friend, she's the chief nurse of Malawi, the government chief nurse in Malawi, said this year they've been battling severe cholera in Malawi. And all of that, then you can see, is really the reality on the ground. I would like to touch on one thing as well, in addition to the health in terms of the diseases and the actual sicknesses. But there is another aspect of this that is often not talked about, and that becomes the humanitarian crisis. I'll tell you what's happening in some of the countries here in Africa: Nigeria, South Africa, Madagascar, and South Sudan. What is happening is that because of this shrinking, and therefore because of people getting sicker, people going to the hospital more, people getting to the hospital and finding no health worker to take care of them, it has resulted in a lot of, I don't want to say frustration, maybe, if I can call it that. So what's happened, for example, in South Africa, they're actually going to their clinics as South African nationals and saying, we don't want anybody who is a non-South African. Because what has happened in a country like Zimbabwe, because the health system has collapsed, the US just brought it completely now down to the ground, the US funding cuts. Zimbabweans go to South Africa for care. People from Lesotho go to South Africa for care. Now, when they get there, the South Africans are like, this is only enough for us. So you guys go back where you came from. South Sudan, we have people now in the northern part of Sudan fleeing into South Sudan because of the war there in the north. The South Sudanese are saying, no. So, we've also become, I don't know how to say it, very intolerant of each other. And that's really, really sad. Madagascar, the same, Nigeria as well. And so, again, those are some of the realities that we are now facing. Perhaps as I close my little speech this evening, I think it's important for us to take 2 lessons. We have the lessons from America. So you who are in America, primarily, especially CUGH and the global north, and wonderful work that you're doing. And Susan, you're already saying you're galvanizing people to go and talk to your political leaders, senators, and so on. The lessons from America are important in that, I think it's important that these things should have been done with a humanitarian lens, if I may say that. At the end of it, it's always it's a mother, it's a father, it's a child, it's a human being. And so just sitting somewhere and just with a stroke of a pen saying, cut this funding, stop this by 24th January, whatever the case may be, it really has a human element. And I think it's important perhaps for America holding that position in the world. And that's sort of how I looked at it. America, it's like when you're a firstborn in a family, you can't evade that place where you were born, where you were, and you can't just say, well, I just go off and do my own thing. And the people who are a little bit after you, perhaps who are weaker, who didn't receive the resources perhaps that you did, you just forget about them or negate that. So I think that's an important lesson for America. But I think another lesson I'd like to say, having worked in this NGO world, if I may call it that, has been that even the way we were implementing our programs, I think, was wrong. So maybe this has been sort of what can I say, a wake-up call in terms of more efficiencies, perhaps going more down to the local ground and understanding what's happening, at least here in Africa, because often the aid flow has been from the north to the south, from the richer countries to the poorer countries. So I think those lessons from America are important. But equally, there are lessons for Africa. We cannot continue to remain in some countries, 3 countries in Africa, South Sudan, which is the other one I've forgotten. There are 3, I've forgotten the other 2. The donor funding, the money that comes from external aid is more than their own government. So that one, I keep telling my friends in Africa, we can't, we can't. We cannot have our own ministries of health, our own countries completely reliant. Yes, Uganda is another one. Countries where they're like 50%, 60%, 70%. I think South Sudan, 90% or 99% of their health budget comes from external aid. So that is a lesson for us in Africa. You cannot cry when someone says, I have problems at home. You've been eating your neighbor's food. No, the neighbor is tired. You better find out how you're going to feed your own kids in your own house, in your own way, with whatever little you have. So I think that's important for us to remember the lessons also for Africa. I think to wrap up, I'd just like to say a lot of this, in my view, in my own experience, in what I've seen unfold in this year, 2025, political leadership is key, both for America, but also for Africa. You've talked about the Abuja Declaration, and only 3 countries in Africa have met the Abuja targets. And if you actually dig deeper, you find it's not consistent year on year. It's South Africa, it's Cabo Verde, and it's Botswana. And this information that I was just looking at, I think only dates back to 2021. So who knows if they continued that now in 2025. So there has to be that consistency in terms of, and that comes with political leadership. Some of our organizations, unfortunately, also don't really bring a lot of joy to our hearts. There's been a lot of lack of confidence in the WHO as a global organization. I don't want to get into the politics. I don't know that. But there has been a vote of no confidence at certain points in time regarding WHO and the way it runs its business. And these are valid points that we need to really address and look at and think about. So again, I always say that leadership is critical. I want to say, though, that it's not all doom and gloom. And out of this, how can I say, out of this peril, there is an opportunity for us to rely on ourselves, particularly here in Africa. We really need to rely on ourselves, but as well to begin to form new alliances. And thank you, Susan, for putting this panel together with all my esteemed colleagues, because I see that these alliances, as we have these discussions, as we talk together, is the beginning of really turning things around. Thank you, Susan, and back to you.
Thank you so much, and thank you for the passion and for really bringing both sides of the coin, the challenges from the sudden contraction of funding, but also what is happening in countries like your own in Kenya, where more needs to be done. So thank you. Now I will hand over to Triza Areri. Triza is an advanced practice nurse at Msambweni County Referral Hospital in Kenya. So really boots on the ground. Triza, we'd love to hear from you what you are seeing over the last 10 to 11 months as things have changed quite dramatically. Thank you.
Triza, you're muted.
I'm trying to do it.
Thank you very much. Yeah.
Perfect.
Thank you very much to the previous speakers. And Susan, I would like to pick it up where Judy left. This has been a wake-up call to us on the ground. We are with the colleagues who've been working side by side with, who have felt this firsthand. And I want to say that coming from what Rachel talked about, of course, the national budgets have not been met according to the Abuja Declaration of 15%. We're already struggling with that. And now the shrinking fiscal space that we have actually been having progressively across the years, and were greatly cushioned by the financing from outside our country. It helped a lot. But now we are having an interesting scenario on the ground, where as a country even, we have a trained health workforce outside the facilities, and yet in the health facilities, we have shortage of staff. Now, many of the financing that has been there has been funding human resource to bridge the gaps, especially in the programs. And so the moment that we had the stop work order, two critical things happened. And one was the shock and the trauma that the human resource suffered when this came up. I like what Judy said. Some of the things that are done need to look behind the political or the policy call to how it affects not only the health worker, but the recipients of care. Now, what we are having in these previous months, first of all, is health workers who are in a space that is psychologically distressing, because for the few months when there's a lot of uncertainty about what happens to their jobs, what happens to the programs that they are running. And even as recent as today, I was talking to one of my colleagues, trying to find out where are you at, even in the face of the extension, because there has been an extension that was given. And one of the things that is that they are not able to operate at optimal levels, because at the back of your mind, two things disturb them. One is about, of course, the job security, the financial challenges that are coming with it, because someone says this has been a cushion for not only for me or my family, but from the extended families, because as in Africa, when you're employed, then you take care of almost all the family members. So it has ripple effects, not only on the economy, it's going to have an effect on the future of many other people. But significantly, it is the reversal of gains made. Judy alluded to it. We're looking at a scenario where right now, celebrating the World AIDS Day the other day, we were talking about one race, one goal, making sure that adolescents do not contribute to the HIV burden. We're talking about the triple threat of teenage pregnancy, HIV, sexual gender-based violence, and now again, a fourth threat, that is mental health for adolescents and young people. So looking at the programs that are heavily supported by donor funding, that is one of the programs that even the health workers on the ground actually ask what is going to happen. After looking at all the input and all the work that has been done or has been put to reverse this, then we are looking at a looming crisis, because the situation still remains the same. The scenario is that we have shortage, acute health worker shortage, and especially nurses. And then we have trained people on the ground, but the country's physical space cannot allow us to employ. So that is a big challenge from where we sit. Then the other thing is about the care models, even in the community. Now, where we were having community health promoters working very closely with CBOs, many CBOs that were funded, we've just heard that there are very few now that are remaining operational. Some have cut down on their jobs, others have actually closed. So healthcare promoters, the community health promoters, were being supported a lot with funding through that. So once we have our primary care networks not working because of the job cuts, then definitely we are going to reversal of the care that is supplied. The care that is offered. We're still having and grappling with maternal mortality. Very sad in this age and time. Every time we sit down to in an MPDSR meeting, that is the review maternal mortality meetings, it is sad because in this age and time, we should not be losing mothers. However, with the cuts and with not reaching the inequality in healthcare services, then we're not able to bridge the gap of equality in healthcare. We have many models for care, and especially the home-based care. And I'm speaking coming from palliative care background, where we would do home visits, but supporting community nurse-led models also becomes a problem. It's a big gap, which would work in the community if we were able to make communities resilient and the health system resilient. But in the face of the financial cuts, then the priorities that are the policy makers focus on, that is not one of them. So we are in a space where care is needed most. We are not able to provide that care where it's needed most. And probably moving forward, looking at this, one of the things that can help a lot is as Africa, or even as a country and communities, like in Kenya, we have counties, because health is fully devolved. And when it's devolved, every county has their priorities. And how I wish, because health inequality or the need for health cuts across the whole country in the 47 counties, would be a priority for them. And so that they also align their budgeting to the needs in the community, just so that we don't reverse or to just cushion the gains that have been made in the health sector. But again, as a country, we would need to look for ways of funding local manufacturing, especially either for our own vaccines or even for our own medicines, and coming together as a continent or as a region would help cushion the finances or the budgets that are needed for large-scale manufacturing and the like. So right now, I would say there's a lot of uncertainty, especially in the health workforce, a lot of uncertainty, because once the health workers who are supported by programs leave, then the remaining few staff also feel the heat and are looking at burnouts. They are looking at a work environment that is not productive, because it becomes challenging to have more workload than what you're having. So quality of healthcare suffers a lot. And so I want to just stop there for now, looking forward to what my colleagues say into this conversation. Thank you.
Wonderful. Thank you so much, Triza. And as everyone can see, it's dark there in Kenya. So thank you all for staying up late. I want to, we just have time for a couple of questions for the panel, and then we'll get over to the second panel. I'd like to ask the panelists here to come off, turn their video on. Yes, thank you. So my question for you, you've all raised a lot of questions, but one of the things that really strikes me is there's two sides of a coin here. Yes, there's been this massive and sudden contraction of foreign investment, especially from the United States this year in health, and we are seeing the ripple effects of that. And Judy and others talked about the secondary impacts, not just the most obvious impacts, but the ones that are more downstream that don't hit the news. But you also spoke about what countries need to do more of, and meeting the Abuja Declaration is one example. I want to ask Dr. Juana, as an economist, one of the things that I saw, we had a project where we helped all of the schools of nursing and midwifery in Lesotho to increase the number of health workers, nurses trained. And we did that, but they weren't absorbed. They couldn't be absorbed in the health system. And I remember meeting with the Minister of Health and saying, what can be done? And he said, I would love to absorb these nurses, but my hands are tied from the conditions of debt loans. And that really has struck me and sits with me till today, because yes, more has to be done for the Abuja Declaration, but the debt that countries are faced with has really hampered in many ways abilities to expand public services. So over to you, Dr. Joanna.
Thank you so much. I mean, it's so timely. We did the health labor market analysis in Lesotho, actually. And we're talking and we're introducing a lot in the health labor market analysis the issue of budget space. Because actually what is going on and what has been going on in the public sector during the last decade and more is that we concentrate in educating more health workers without seeing how are we going to provide the jobs of these health workers. And it's not just about opening the vacancies, but we see also unfilled vacancies, right? So this is about distribution and lack of remunerations that are expected by the investment of health workers. So all of this comes into also the health workers are human beings, so they are driven by incentives. It's not just about altruism, but it's also about you have a family, so you're not going to a remote area if in that remote area you don't have schools for your family or jobs for your spouse, right? So all of this requires coordination with other ministries, because if we think about rural areas, then you need also to bring the Ministry of Labor and the Ministry of Education to put together the things that they already are doing at the national level, which is building schools, providing jobs and all of that, but focusing on these areas. Rural pathways, that's what we call rural pathway, and needs working, but we haven't been able to multiply it or expand it in many countries. So that's one thing. Specifically on how can we finance more jobs, there are many things, and is that the Ministry of Health doesn't speak that same language as the Ministry of Finance. When you go from the Ministry of Health to the Ministry of Finance asking for budget just because you need health for the population and all of these, the Ministry of Finance will be practical because they know the business. They will tell you, yes, all right, but you have inefficiencies. You are not spending efficiently. Sometimes the budget that I give you, you don't spend it at the end of the year. Sometimes you have ghost workers, a question that was put in the chat actually. Yes, you have ghost workers, and we know that. So what's going on? You have beds that are not there. So what's going on with that service? I mean, the Ministry of Finance knows the issues. So the thing is, like, we have to start changing that dialogue. So we have to use the 3Ds plus 1Ds that we use in WHO. They say like the data to enable dialogue, to enable decision making, to find dollars, which would be the money, right? And how do we do that? We need from the Ministry of Health to start understanding how to process a budget and to understand our inefficiencies. In Lesotho, we found with the health labor market analysis that filling a vacancy takes more than a year, which is more than the period of the fiscal annual part of planning. That means that if you don't manage to fill it during the year, then you will lose that money. So vacancies are unfilled, but are unfilled because you don't manage to in the admin part. So we are losing resources because of the admin. If we sit with the Ministry of Finance saying, we understand these are our issues, this is our plan to address these issues, we engage with this, but at the same time, you, Ministry of Finance, support me to improve this. So if we get that understanding, we have managed to do it. Tajikistan, Central Asian country, we managed to sit. At the beginning, it was impossible. But when we started to analyze this from that perspective, saying, we are seeing this, let's do it together, and we can increase. Countries in South America like Chile, they have managed, and they are managing to plan their budget together with the Ministry of Finance with agreed indicators in order to increase little by little. So I feel like this thing of data, dialogue, and decision making to bring more budget is key. Plus, I will add one thing just to finalize, and is I think we need a new global compact to fund health workforce and health. This year, health and health workforce have been put into questioning, something that we have already overcome decades. And we need to bring back a fresh conversation around this. So we have a global compact on this. Thank you.
Thank you so much. My head is swirling with ideas and really unpacking the nuances here. It's very challenging. It's a very complex problem. And what's really coming to fore is, for me, is frontline health workers and advocates for frontline health workers have to develop the leadership skills, the advocacy ability to be that connector of why the return on investment is so important. We have that, but also within ministries, how to have health systems that are responsive and resilient in a way that ministries of finance cannot avoid how important investment in healthcare is. And so we're now very short on time. So I just like one quick sentence from Rachel and Judy and Triza in response to that leadership, that advocacy, that ability to have a compelling voice from the front line to leadership, both at the Ministry of Health, but more importantly, at the Ministry of Finance. So one sentence, Rachel.
Oh, wow. I mean, I think that is key. Data needs to drive this. I think that there's a lot of good work with the Africa Health Workforce Investment Forum that took place in 2024. I think that ministries of health, finance, and even education and their partners are going to continue to come together. We need to look at what opportunities there are at the local level and within the national private sector to fill in a lot of the blanks and create the jobs and keep health workers where they're needed most. Thanks.
Thank you. Thank you. One sentence, Judy. You're on
I
mute.
think agreed. And for me, it's important as well to work together. You find that the lack of coordination between, even when we had funding, so between NGOs, for example, on the ground, the Ministry of Health, the facilities, the educational institutions, the regulators, we've often worked in silos, and that has also not done us good. And I like what Dr. Juana is saying when she says the Ministry of Finance speaks this language and the Ministry of Health speaks a completely different language. We have to start speaking the same language. And maybe efforts should be made towards giving us the skills to speak that same language. Particularly, I think, for the frontline health workers, often nurses and midwives lack those skills, and equipping that frontline health workforce to be able to put forward. So like Teresa, if you're in the DHMT, are you able to speak that language, that in the nature of your work, what does this mean if it's going to take 1 year to bring a nurse on board? So what are the words that make sense to the Minister for Health when you are passionately advocating for a nurse to be there because there are too
Thank
few
you.
and he doesn't understand? So
Yeah.
then what do you need to do to be able to upskill yourself to then tell him this is what it is? Because at the end of the
Right.
day, the dollars are limited. So
Yeah.
even reducing those inefficiencies, eliminating the inefficiencies are also incumbent on us. So we also on the health side have to clean up our act. Back to you,
Thank
Susan.
you. Thank you. And Triza, come off mute and one sentence from you on how we can drive leadership so that frontline, the absolute necessity of investment in the front line is made clear. Over to you, Triza.
Yeah, thank you very much. And I want to overemphasize the issue of language. Very important. In our country also, we've gone up to the Ministry of Health and talked to them and said the Ministry of Finance just doesn't get it. So we need to find this language that we all speak. But most importantly, we need to have mentorship trainings for nurses on the ground to be able to advocate where they are at with what they have, not necessarily relying on the leadership of the profession, but every nurse, wherever they are, to be able to lead advocacy for themselves and for the patients that they serve. Thank you.
Thank you. Thank you. And one of the comments that just came in the chat box is, should we in health workforce training, in health worker training, have courses on health financing so we know how these systems work and we can be at the table when these decisions are made. And my colleague, and I'm going to hand over to her, Allison Squires, Professor Squires made the important point about the triple impact. And we have the data that shows the triple impact of investment in health workers. And Nigel Chris wrote the triple impact report specific to nurses, but it really is for all frontline health workers. Investing in them improves health, improves gender equality, and we know gender equality improves the family and children, and then improvements in economic growth. We know it's clear, but we have to have the data. We have to be able to dialogue with a compelling voice, and we have to help make right decisions that drive healthcare, health financing that's robust. The task ahead of us is great, but we can do it with passion and desire and networks and connection here. I'm going to hand over to my colleague, Professor Allison Squires. She is the director of the Global Consortium of Nursing and Midwifery Studies. She has a longitudinal study working with nurses on the front line. She's a professor at the Rory Myers College of Nursing at NYU. Over to you, Allison.
Thank you, Susan, and thank you to all of the previous panelists for a really productive and fruitful discussion. I always love participating in a panel where I'm learning new things and gaining new insights. So for our panel, we are going to be talking and focusing on policies and donor perspectives. And just like we have a wonderful session here with our fellow panelists, including Geraldine Hoover, who used to work for USAID, doing a variety of things. We'll let her do the brief intro when she's ready. We also have Meredith Fent Newland here with us, who works in health worker mental health for the WHO. And then also we have Peter Waithaka, who's the Secretariat Lead for CHU for UHC, and was also with USAID in Kenya. So we're going to start with Meredith because we've talked briefly about we talked about the mental health impacts in the previous panel. Meredith, can you talk about what you're seeing and also thinking about the future policy implementations? Because I'm immediately thinking like the need for scaling mental health capacity in this, especially after the pandemic and then after this year, is going to be critical.
Thanks so much, Allison, and thanks to the rest of our panel members as well. You know, we've heard so much from our colleagues in the first panel about what countries are facing. And there's really this intensified health workforce crisis that we're seeing. And it's not because the need has diminished for health workers, but it's because of these financial and political commitments, and sustaining them has really come under pressure. So we're seeing that funding cuts are being driven by this fiscal strain, the shifting political priorities. And in this environment, unfortunately, development spending and workforce budgets are becoming those easy targets. So there's a lot of sort of short-term decision-making that's happening, which is having long-term consequences. I'll talk a little bit about what we're seeing in terms of government spending, what we're seeing in terms of priorities of countries, where some of the sort of gaps might be as far as the health, the workforce environments, mental health and burnout that we see from that as well. But I also want to talk about a specific initiative that my colleague Juana Paula had alluded to a little bit, but the Working for Health program, which is really cutting across ministries and trying to take a more multi-sectoral approach, which I think is really one of those key needs that we have going forward. We know that in the COVID pandemic, a country's ability to be able to detect and respond and recover really depended on its people. The nurses, midwives, doctors, community health workers, emergency responders. We know that if we're cutting workforce investment, we're ultimately cutting health security. And what we saw in the COVID pandemic in terms of mental health, as you were asking about, Allison, we saw very high levels of anxiety, depression, post-traumatic stress, and levels up to 50% of burnout in some countries and in some groups. But what we're learning is that those numbers, those mental health impacts are really not isolated just to the pandemic, but we've done a review which was published this year, which looked at post-pandemic rates of mental illness. And we're seeing those rates are still very high and still so much higher than the general population's impact that they see from anxiety and depression and burnout. So we still have this ongoing issue. It's really to show it's not isolated to the pandemic. It's not isolated to what we thought was sort of an acute emergency. But the mental health impacts for health and care workers it has sort of this ripple effect as well, where it's impacting burnout, it's impacting the efficiency, the effectiveness of really limited health services in a lot of countries already that are already under a lot of strain through the shortages and through the workload pressures that the workers are facing. I want to talk a little bit about the aid spending and some of these impacts that we're seeing and how that then translates into what health workers are faced with. But looking at the last 5 years, external aid represented a large share of the total national health spending in low-income countries. A couple of colleagues had mentioned that earlier. And yet the health and care workforce received only a very small portion of that support, so roughly 5%. Whereas governments were allocating about 55% of their domestic health spending to the workforce. So external aid is remaining heavily skewed towards training, which accounts for 43% of all health workforce investments from external aid between 2016 and 2019, and that rose to 55% during the pandemic. Now, Rachel mentioned earlier that donors are not tending to fund salaries. And as Judy shared, countries are very far from meeting the Abuja Declaration targets. But as a result, we're seeing that aid flows are misaligned with country priorities. They're concentrating on short-term training rather than a broader systems level investment that's needed for a sustainable workforce expansion. And at the same time, what we see is that health labor market absorption remains a major challenge. So 1 in 3 of Africa's newly trained qualified health workers fail to get a job in the first year. And underemployment for health workers in countries with critically low health workforce shortages already is estimated at 30%. So as Trizza had mentioned earlier, we really need to focus on work environment. We really need to focus on workload and burnout. We need to find more sustainable approaches that are not just project-based, focused on training, but we need to look at how to sustain workers with how to get them jobs, how to sustain them within their jobs, retain them where they're needed most. I think the evidence is clear. External aid has not historically aligned with these domestic realities. And from WHO's perspective, I think one of the core challenges is that health workforce investment is consistently misclassified. It's treated as a cost to be contained rather than being a long-term economic and social asset. As Susan had mentioned as well, this sort of triple impact. But the return on investment is really strong. So for every health worker that's employed, 3.4 additional jobs are created, and 60% of the health workforce being women, that investment fuels gender equality and youth employment. So the question is, where do we go from here? What are the efficiencies and some of the new models that we want to look at? And as Juana Paula had mentioned earlier, working across ministries, working across the sectors is really important. I see a real opportunity in shifting from these fragmented project-based funding towards a multi-sectoral, pooled, or blended financing. So I want to give the example of the Working for Health program. This is a collaboration that WHO has with ILO and OECD, and it's a good example of aligning labor, education, finance, and health sectors to create this sort of shared financing pathways between education, jobs, decent work, mental health, retention strategies, and really that system strengthening. So when we are supporting countries, we're using that 4D framework. I'll come back to that. The data with health labor market analysis, providing the evidence base on which the policies are based, the dialogue across the different sectors, decision-making through the strengthened and costed strategies, and the dollars in terms of assisting countries to prepare and implement for their investment. And I can certainly talk about some of the examples in countries, but I'll maybe wait for breakout groups or wait for some more of those sessions here. But I think with relatively small investments, we can see delivery on these economic returns, on employment, on health system returns. And I think all of that is needed sort of as in combination. And again, Allison, I can come back to some of the mental health stuff, maybe with some of the questions and some of the breakout groups. Thanks.
Sure. So, Geraldine, you were doing a variety and building off of what Meredith said, your role at USAID was doing a lot of that capacity building and training. And, and I think, we've and side discussions we've talked about how the training system for producing, the production system for producing health workers seems to have stabilized globally. And like Meredith mentioned, what we really need to be thinking about is retention and organizations, and of course the financing piece. So Geraldine, drawing from your experiences and what's been said today, what are your thoughts, and where do you think the next steps are for addressing these issues to really improve global health security when we're thinking about this in a big picture sense?
Thanks, Allison, for that question. And I'm really happy to be here with all of you today and see so many friendly faces. As Allison mentioned, until earlier this year, I worked at USAID based here in Washington, and I led on health workforce strategy through the lens of my own experience as a nurse. And before, most of the other people who've spoken have talked a lot about the impact of what has happened this year. But I just want to reiterate something that Rachel and Judy mentioned as well, that USAID funded programs enabled health workers to do their jobs in a lot of settings. And that was across a spectrum from providing supplies and commodities that they relied on to be able to serve their communities to, in cases like the PMI program or the PEPFAR program, we directly employed hundreds of thousands of health workers that filled critical shortages across a lot of countries. And so with almost all of those programs gone, those effects have affected the whole ecosystem of health in ways that other panelists have spoken on. The organizational disruption, we've lost convening platforms that historically have brought governments and stakeholders together to make progress on health workforce priorities. And then the job losses piece. So Teresa and Judy shared really concrete examples about that. But something I want to point out as well is that for programs like the PEPFAR program, that in addition to providing workforce development and capacity building and support, the PEPFAR program also was a service delivery platform. So it directly supported health worker salaries in ways that a lot of other development programs did not. Take last year, for example, PEPFAR supported over 220,000 community health workers and nurses. USAID had over 50 to 60% of that support portfolio across countries. So very conservatively, just for nurses and community health workers. And we know that there are many more people outside, many other types of health workers that were supported. That means over 120,000 community health workers and nurses lost their jobs over 50 countries in the last year. These are people that had worked for years and in some cases decades to help keep their community members safe and healthy. And then overnight, they lost their jobs. They saw that all disappear, and they were forced to watch those same community members show up to clinics that were closed and to go without medications that they needed. As others have said, this has had devastating and fatal impacts, both for health workers and for patients. For me personally, it has hit really hard this year that for so many years, USAID worked to improve work environments and to create conditions that made it easier for health workers to do their jobs with less understaffing and with fewer supply chain issues. And I felt a lot of anger that these efforts were apparently fragile enough that with a signature, so much could be swept away and so much trust could be lost. And that, as others have said, the US has clearly not demonstrated that they are a trustworthy partner in any point this year. And I felt grief that overnight this created the very types of conditions for moral injury and burnout that we worked so hard to try and prevent for so long. And I think this hits types of health workers differently, but particularly for community health workers who in many countries are not formalized and do not have formal professional status or paid roles. They're much more likely to be overlooked in any attempts at absorption efforts or trying to kind of shuffle and find new funding. Those are the community health workers and social service workers, I think, are the most vulnerable workers as we think about the wraparound supports needed for all types of healthcare. So for malaria services, community visits, global health security and contact tracing, HIV care. So I think keeping community workers at the forefront of our mind as we're moving forward and engaging in advocacy is really important. And just the last piece that I wanted to share, since my background has been from working within the U.S. structure. The administration put out in the last 2 months a new global health strategy that outlines an approach for direct bilateral agreements with priority countries. And those negotiations are happening right now. So in many of the countries where we have participants, that is something that is happening right now. And on paper, that strategy commits to maintaining 100% of support for health workers that are delivering services. I see this as an opportunity and a risk. So on the one hand, countries that know their health workforce gaps well, they can leverage the information systems they've had for a number of years. And if they choose to engage in this process with the US at this point, they could leverage those agreements to support critical positions in a strategic and phased way. But a risk is that in countries, like I mentioned, where community health workers are not already formalized or paid positions, there's a lot of workers like community workers that are likely to be overlooked in this process. And a really fundamental problem with this strategy's premise, and frankly, I think it's something that has pervaded health workforce issues globally for a long time, is that the strategy rests on this idea that sounds really appealing, that every health dollar should go either directly to commodities or health worker salaries, and that everything outside of that is waste. But that's a dangerous oversimplification because we know that health workers cannot deliver quality care without functioning systems behind them. They need all of the things that other people have shared. And if you take those things away, you're not maximizing efficiency, you're setting health workers up to fail. And speaking of the global health security perspective, we've seen this in the last 5 years during COVID, when we underinvest in health systems and we require health workers to always act like isolated heroes for things to function, we get bad systems and bad outcomes. So I have a few more thoughts on kind of next steps and call to action, but I'll pause there for now, and looking forward to the continued discussion.
Great. Yeah, I think where we've seen is in terms of global health security, really the threats to resilience of systems the system shocks that have happened this year have made all of us more vulnerable to pandemics, to other security issues, to natural disasters. And these are in the long term going to threaten economic stability and national security. And unfortunately, it will not help with future international collaborations that help promote global health security as well. Susan, I recognize that we are at time for our panel, and it's, as usual, a sign of a good panel. We could continue this conversation for so much longer, but I know we want to have space for breakout rooms. So Susan, do you want to guide us into the breakout room session of our discussions?
Sure. Is Peter here? I'm not seeing his names on the panelists.
I think, unfortunately, Peter's been having trouble joining.
Okay.
I think he's here. I think he may be logged in as a separate Susan account. Is that your hand raised, Peter? If it's so, I will assist with changing your name.
Peter, if you're there, if you can come off of mute and let us know.
There we are. Peter, sorry, I'm glad that you were able to connect. Given what we have just briefly discussed, could you give us about 3 minutes perspective, which I know is not enough, but we do want to make room for our breakout rooms as well.
Peter, we can't hear you. If you can, in the bottom left hand of your screen, find the test speaker button, you may be able to test your audio and get it working. I can also work with you in the background if you want to proceed a little bit, Susan.
Okay, all right. And please let me know, Ian, Peter, if we get the mic working. Thank you, Allison, Meredith, and Geraldine, really adding to what has everything else that has been said and bringing in the policy and donor perspective and continuing to look at the nuances, but really highlighting return on investment in the health workers and in the health system for health system resilience. As Allison said, we want to move now into some breakout rooms, and we have 3 questions for you. We'll take about 15 minutes. We don't have the 30 minutes, but we'll have about 15 minutes to hear from you about the way forward. We'd like you to reflect on today's sessions as well as your own experience to brainstorm strategies in 3 areas: to sustain training programs, to mobilize alternative funding sources. And this includes not just donor sources, but as many of our panelists have said, greater investment from within national ministries of health and commitments from ministries of finance. And then lastly, identifying priorities for policy and advocacy for those who work passionately to drive an advocacy agenda for frontline health workers. So our speakers and panelists will facilitate the breakout rooms. We'll take about 15 minutes. You'll get a 2-minute warning when the breakout room ends. And I would like the facilitators to come back with 2 to 3 concrete things that we can do from today's session to bring forward immediately in the short term, but also at CUGH next year to continue to develop a call to action, sustaining workforce training and capacity building, mobilizing alternative funding, and identifying priorities for policies and advocacy. Thank you, Ian, for putting us into the breakout rooms. As everybody returns, if I could just ask the facilitators if you could type up the bullet points of what was said and share that with me as we move forward. But maybe I'll just go around and ask breakout room 1 if you can share a few thoughts with us in the remaining 9 or 10 minutes that we have.
Sure. So we had a very nice discussion with some great ideas put out there. One is, I think, reducing the risk of fickle political partnerships, of, trying to strike a balance between the need to change and address institutions that may need radical change without, shall we say, basically running over everything and knocking it down, as has happened this past year. Also, thinking about ways to make ourselves irrelevant, basically by reducing dependency and understanding what it means, to go in with the idea of you should do such a good job that no one should ever need you again. And there will be new things that will come up. There's no question. So you can still keep working together if that were to prove to be a fruitful partnership, but really focusing on making ourselves irrelevant. Also, this idea of understanding what it really means to have economic well-being for a health worker, because we've talked about the return on investment that health workers provide, but we really have to understand what constitutes economic well-being for them, to understand what are appropriate salary ranges for people across the world. And this is true everywhere. This is not a mutual, affects every country. And then I think finally, we were also talking about understanding what is the half-life of clinicians. Old models expected people to stay in their jobs on the front line for 40 years or 30 years, whatever the retirement age was. And that's not necessarily realistic. And, physically, maybe your back and knees are going to give out after 15, 20 years. So, but you should be able to still stay working. And so the idea of rethinking these models that really understand what are clinician career trajectories. How many do you need to stay working on the front lines? How should the production system replace people sustainably, but also account for the fact that people are going to want to advance in their careers, and they should be able to do that domestically within their country. And, career advancement is one reason why people migrate. So trying to strike that balance. And that was sort of the core things around what we were talking about.
Excellent. Career pathways to allow those experienced nurses to move into new positions, leadership positions. Excellent. Thank you. I think I was breakout 2. Is that correct? I think so.
I think that's correct. Yes.
Okay, thank you. Yeah. So Angela from Johns Hopkins really got us started, and I want to thank you, Angela, and love to talk to you further in the future. And really pointed out, and this really goes across all 3 questions around sustaining the workforce, alternative funding, and identifying policy and advocacy. She really encapsulated all of them in her answer, and we continue to talk around that. And basically what she said is we are playing catch up with health workforce development, and this is part of the frustration or maybe the reticence in financing health workforce and capacity building, is because the constant training needs really show that the basic education has some serious challenges, and capacity building needs to be done in basic pre-service education. Academic universities and teaching hospitals need to be prepared and work harder to decrease the disconnect between education and what is needed when they get out into the workforce. Obviously, there will always need to be updates and training, but taking people out for 5 days or 10 days to teach them essential skills for what they need to do in the workplace is not sustainable. And the monies that we saw in the early years of PEPFAR to train people to provide HIV care, that's not going to be there in the future. And so really getting back to basic education and making it very, very relevant for the workplace. And I love what she said about when you do that, you have those that take the health workers who are ready and able, they hit the ground running, although they need experience, they really have that essential knowledge and skills to really begin being productive. Whether it's the public or the private sector, they see that. And then the investment back into education increases. So it's a positive feedback loop. A couple of other things that were said right at the end, we need to, with this new normal of changes in large donor government bilateral agreements, is building public-private partnerships, using a systems approach in evidence generation, using national health workforce account data, national health workforce labor market analyses, to use that data, as Dr. Warner said, the data, the dialogue, and for better decision making. I'll stop there. So we'll go to breakout room 3.
Thank you, Susan. Very quickly, we had a very vibrant group. Thank you to the team. Very quickly, one of the things that was said, I think the team was mainly made up of those of us from Africa. The shortage is not as dire as it's made to seem. So that's one thing that came out. And then the need to use the resources in the community we already have, not even financial, but what are the resources, the knowledge, the skills, the history, whatever works there. So really our workforce is probably more underutilized. And then the issue is more the shortage of money. So it's what you alluded to, Susan. Training is one thing, but absorbing is another. How do we make sure we absorb these workers as much as we are focusing or struggling to train them? I think advocating for government to get funding. Our health workers need political skills, financial skills, communication, advocacy, reading the room, and all those skills they never teach us in nursing school. Overturning the health system, I think the vertical model is now obviously not serving us well. These structures, particularly in countries like, in Africa and Kenya, where you have 6 tiers within the health system, 5 or 6, level 1, 2, 3, 4, 5, also doesn't help. And results in a lot of waste and inefficiency. Taming corruption also reared its head, as it's bound to when you're in Africa. And there was also a mention of investing in telehealth or telemedicine, very important. So that's really utilizing that. And Nancy mentioned very early on virtual training. So we can train people virtually, and we've proved that it's possible even in Africa with the challenges we have of internet. That has been very, very successful. Investing, and you mentioned this, Susan, in pre-service training, so that the worker you get out is well skilled across the board, particularly with the multi-morbidities we see and the chronicity of everything. We are now not training, you're training to look after the whole. And again, last but not least, moving away from verticalized programs, the HIV,
I like that.
the malaria, and sort of integrating was some of the things that came out. Back to you, Susan.
Yeah, integration. I think we could, if we had more time, to talk more about integration and having economies in scale and how we deliver healthcare. PEPFAR did in many ways became a vertical program, and we need to reintegrate into services, for example. Group number 4.
Yeah, that was the group that I facilitated. And I'll keep this super brief because I know we're short on time. But one of the comments, some of the comments that our group had that I thought were really interesting were talking about how the what we have seen this year can be a driving force for more innovation, more use of satellite care in more consistent ways, where you don't need specialists to be in all of the places. You can use virtual and remote care to extend the reach of the services to more rural areas where it might be harder to keep providers posted longer term. Also thinking about innovative ways of employing people. So not just thinking public sector or private sector, but someone brought up the idea of supporting kind of self-employment or private business structures for health workers who would like to go this for themselves, like self-employed midwives, for example, communities where there cannot be a public sector midwife because of financing reasons. So I think there's interesting things to explore there. And then last was what Dr. Juana Paula added again on really supporting dialogues between ministries of labor, finance, health, and education, given that everybody has a stake in this. It's an issue of youth employment. It's an issue of finding efficiencies and allocation for health budgets to meet the needs in the country, working in concert across those groups of stakeholders. So I'll stop there.
Awesome. Thank you. So many good comments there, and really emphasizing remote care and also private nursing practice. I know that's done in South Africa, private midwives, so private practice midwives. Group number 5.
Teresa, would you like to summarize our discussion?
Okay, thank you. I think we were very lucky to be 2 of us in that room, and we had good conversation. It resonates with what we have said. And in trainings, we picked up that strengthening supervision post trainings of what happens, like most of you said, what happens after the training? Does it resonate with what is on the ground, the current one? And there has to be continuous training, and preferably online training, because now that can reach very many people without removing them from their workstations where there is shortage. Because most of the times, like in the current setting, even people are not being released to go back to school, and yet we need to upscale. So you find that it is not possible. So if we have modules that are online, that would be very well preferred. But most importantly, also strengthening the supervision post-training, either through mentorship and coaching. We strengthen the supervision for the outcomes after that. And using just local TOTs, local specialties in the space where health workers are. And in regards to alternative funding, we said it is possible to borrow heavily, like during COVID time. We saw a lot of people in the social space, private space, coming on board to support governments during that time. And so it's something we can still look at so that we start having conversations, small conversations at community level. What can community resources do within their own space? Maybe just having a shelter for women who will not have transport to travel during delivery, and so we have these shelters that we have, and also the people in private sector within the localities that are existing. So that can be a good source also of alternative funding, so that we stop focusing on the big funders. When we talk about partners and we think big funders, yes, we can have local funding. And then we were kicked out of the room.
I love, we've had very high level ideas for interventions with the WHO, but also very grassroots. And that's what it's all about. We have to be able to bridge the real world frontline with the macro policies and advocacies. Otherwise, there's this huge disconnect and we don't change. Thank you all. We're at time. We've had a great, rich discussion. So much has come out of this. I'm going to ask our facilitators again to share the comments with me. If you look into the chat, there is a link to this recording, and please share widely. Join us for CUGH 2026, where we will continue to develop this. I hope to have a published manuscript of these proceedings so that we can begin this call to action. So much than I ever thought came out of this, and I really think we have nuggets of very important advocacy pieces of work that are concrete that we can do together. So thank you all for being here. Thank you for your time, your energy, your passion. We're all in this together, and together we can come out of this stronger and more sustainable in driving healthcare for all. Thank you all.